Welcome to Chemotherapy SDI 471 Advanced Studies in Human Oncology 1 for Ben Morris. My name is Jamil Kelly Tweet, and I'm a BSN-RN with a national certification as an oncology nurse. I'm the Assistant Nurse Manager of the Cox Cancer Center in Branson with 32 years of oncology experience and 40 years experience in nursing. This is the outline for our objectives today, which you can refer to as needed in the future. Let's go ahead and talk about the history of chemotherapy. Prior to the advent of chemotherapy, surgery and then radiation were the only means to treat cancer. Cure rates were very poor. During World War II, the military was developing nitrogen mustard as a chemical warfare agent. It was discovered that nitrogen mustard evoked beneficial results in men with cancer of the lymph nodes or lymphoma. Continued research led to the development of alkylating agents, which are drugs that kill rapidly growing cancer cells by damaging the DNA. Soon afterward, Dr. Sidney Farber, a pediatric pathologist, discovered a folic acid-related compound produced childhood acute leukemia, which led to the development of methotrexate, a chemotherapy drug still used today. Dr. Farber helped found the Dana-Farber Cancer Institute in Boston, Massachusetts, which is a teaching facility dedicated to cancer, pediatric, and adult research and treatment. In 1956, methotrexate cured a rare choriocarcinoma tumor, which is a quick-growing cancer of the uterus. In 1960, chemotherapy treatment started to produce remissions and cures in patients with Hodgkin's disease and childhood acute lymphocytic leukemia. The 1970s saw cures for testicular cancer in addition to lengthened lifespans. Today we have new drugs, new delivery routes, combination therapies, improved side effect management, bone marrow transplant, and clinical trials, all methods we use to help treat and find new treatments for cancer. The concept of bone marrow transplant actually began in 1896, but it wasn't until the 1940s and World War II that serious research began. In the early days, bone marrow was harvested from a healthy donor and infused into patients exposed to lethal doses of radiation. Many early transplant patients did not survive, and some only gained remission to die from transplant complications like infection or graft versus host. Today, transplant is still a serious undertaking, but many more survive. Chemotherapy and sometimes radiation therapy is used when preparing someone for a bone marrow transplant. Chemotherapy destroys the patient's existing bone marrow cells and any residual cancer cells, and then stops the functioning of their immune system. It takes about a week for all of this to occur. The cancer patient then receives an infusion or an IV infusion of stem cells, which is the actual transplant. These stem cells could be their own or another's harvested stem cells that are administered via an infusion in the IV. Hopefully, these newly infused stem cells will stimulate the patient's bone marrow to produce new, healthy blood cells, which will lead to a remission. Clinical trials compare new treatments to standard treatments in an effort to identify and understand benefits and risks for changes in standards of care treatment. It can take as long as 20 years before a drug receives FDA approval for outside of a clinical trial. The National Comprehensive Cancer Network, or NCCN, is an alliance of the world's leading cancer centers and is an authoritative source of comprehensive cancer care. It's dedicated to the research that improves the quality, effectiveness, and efficiency of cancer care and offers a number of programs that give clinicians access to tools and knowledge that can help guide their decision-making when determining the management of a patient's cancer treatment. There are many steps to follow in the development of new anti-cancer agents, which are very complex, as well as time and resource consuming, not to mention very expensive. 20 years to develop one drug. Can you imagine the cost? National Cancer Institutes, or NCI, and U.S. government examine thousands of chemicals yearly to discover new agents for testing. The NCI is a great web resource site for many people with cancer. Only a small percentage are selected of these new drugs for preclinical testing, and even few are tested in phase 1 clinical trials, which is starting treatment treatment on patients, actual people. Determining treatment by the physician, oftentimes the provider will use NCCN guidelines. and they plan the patient's treatment regimen according to NCC guidelines and other factors. Depending on pathology findings and diagnostic tests, staging will be determined, which allows the provider to individualize the patient's treatment. Some tumors are more aggressive than others, which means the cancer grows or spreads more quickly, and treatment will most likely be more intense. Small cell lung cancer is an example of an aggressive, fast-growing tumor. Of course, since treatment is individualized, the patient's overall physical and mental status will play a part in which treatment will be best and meet their needs accordingly. Those with poor performance status may be unable to tolerate the most appropriate NCCN recommended protocol, which might necessitate adjustments in their treatment. A patient's age will not prevent their receiving treatment unless age is accompanied by poor mental or performance status and/or the patient's refusal to undergo treatment due to their concerns about potential treatment-induced reductions in their quality of life because of side effects. Outcomes deals with potential for cure or remission, the need to shrink tumor prior to surgical removal, and palliative treatment for symptom management only. Whatever treatment is selected, prolonging survival while maintaining good quality life is a primary goal. There are many different types of medications that we use for treatment, and each of these treatment modalities will be discussed in further detail except for gene therapy, which is investigational at this time. So we have anti-hormone therapies, chemotherapy, which is really anti-neoplastic therapy or drugs that kill cancer cells, targeted therapies, immunotherapy, bone marrow or stem cell transplant, which is the same thing, and gene therapy. So let's start with medications. Anti-hormone therapies suppress tumors that grow more rapidly in the presence of certain hormones, like estrogen. Chemotherapy works on fast-growing cells. Systemic therapies, which means we give it into a vein and it goes throughout their bodies, except it doesn't typically cross the blood-brain barrier. Chemotherapy may be used alone, before, or at the same time as radiation therapy. So the patient would receive chemotherapy and radiation therapy during the same treatment time frame. Chemotherapy is limited by toxic effects on normal tissues, and the patient may not be healthy enough to receive chemotherapy or all their doses or the recommended dose according to NCCN protocols. Other classifications include antimetabolites, which are drugs, chemotherapy drugs that damage cancer cells' DNA and RNA. We have alkylating agents, which damage cancer cells' DNA. We have anti-tumor antibiotics, which alter a cancer cell's DNA so it cannot grow or multiply. Then we have plant alkaloids, which attack cells during various phases of cell division. And I'm not going to say this one really well, but it's topoisomerase inhibitors, which interferes with enzymes needed for DNA replication. Then we have mitotic inhibitors, which interfere with cancer cell division and/or inhibits enzymes needed for cancer cell reproduction. Targeted therapies are rather new, and they attack the inner workings of the cell that make the cell, which makes that cancer cell different from normal cells. Targeted drugs kill the cancer cells by different means. They block or turn off chemical signals that tell the cancer cell to grow and divide. They might change proteins within the cancer cell so the cancer dies. They could also stop making new blood vessels so the cancer cell has no nutrition from a blood supply. Some targeted therapies help a patient's own immune system be triggered to kill the cancer cells. Some carry toxins to the cancer cell that kills them, but it doesn't irritate normal cells to such an extent that they cannot recover. The pictorial you see here depicts a blocking targeted therapy called Herceptin, which is used in the treatment of some breast cancers for patients who are HER2 positive, and we discovered that during our staging phase. Immunotherapy is another means to treat cancer, and the patient's immune system may be stimulated by an immunotherapy we administer. It may be enhanced or it may be suppressed depending on what the patient needs and what we administer. It's used to treat some cancers. It's also used to treat chronic hepatitis B and C, and oftentimes we'll get immunotherapy for non-cancer related diseases such as rheumatoid arthritis, multiple sclerosis, psoriasis, Crohn's disease, and ulcerative colitis. A bit of history about immunotherapy. Dr. William Coley did extensive research on the use of immunotherapy in the treatment of cancer in 1891. One example of current use of immunotherapy began in 1976 when researchers started using immunotherapy to prevent recurrence of bladder cancer. Tuberculosis vaccine, Bacille Galmet-Guerin, or BCG as we call it today, is still used in the treatment of bladder cancer. Non-Hodgkin's lymphoma, metastatic kidney cancer, and metastatic melanoma are other examples of immunotherapy-treated cancers. Neoadjuvant is a term that many clinicians utilize to decide or to identify what's happening with the patient's treatment. For example, neoadjuvant means they're going to get chemotherapy or radiation before a surgical resection. Why do we do that? Well, it makes the cancerous site more easily resectable, and it can preserve local organ function because of compressions or something like that. This works really well in inflammatory and locally advanced breast cancers, stage 3A lung cancer, bladder cancer, nasopharyngeal, and head and neck cancer. Another one is adjuvant therapy, which means chemotherapy, radiation, anti-hormone, targeted, or immunotherapy is given after surgical removal. Goal is to eradicate residual tumor that's left over, increase disease-free survival and cure rates, and reduce recurrence in high-risk patients. This works really well in breast cancer and colorectal cancer. When we treat patients with cancer, oftentimes we'll use combination therapies instead of single-agent therapy. That talks about using more than one type of cancer drug or cancer-assisting drug to help kill the cancer. Why do we do this? Well, first of all, it maximizes our cell kill for the cancer cells. Also, it reduces organ toxicities. There are some medications that we use with cancer drugs that help enhance how those drugs work. They maximize the effects of another drug. One is called Avastin, which is used with GI cancer protocols and causes a depletion of the tumor's blood supply. Another medication we use often with 5-FU or fluorouracil is called leucovorin. Leucovorin helps increases the cancer cell susceptibility for 5-FU to get in and kill that cancer cell. Agents used in combination therapy can be used as single agents, but they work much better when we use them in combination. So there are different routes of giving chemotherapies. We have intravenous, subcutaneous, oral, intravesicular, intramuscular, intraarterial, intrathecal, intraperitoneal, and topical. Most of these are self-explanatory. However, I do want to clarify several. Intravesicular often refers to installation of chemo into a patient's bladder, and that's obviously to help prevent bladder cancer or to treat possible bladder cancer after a patient's had surgery. Intraarterial often refers to administration of chemotherapy directly into a main artery, such as via the hepatic artery when someone is being treated for liver cancer. The picture in this slide shows administration of chemotherapy into the cerebrospinal fluid into a patient's brain ventricle via an Ommaya reservoir, which is also referred to as intrathecal. This is always done by a physician who is trained in this type of therapy. Intraperitoneal often refers to administration of chemotherapy into the peritoneal cavity for the treatment of ovarian and gastric cancers. When we give antineoplastics or chemotherapies, there are some considerations that we must follow to ensure that everyone involved has safe handling. And let's talk about safe handling. The reason we follow these guidelines I'm about to talk about is because many of these drugs are considered to be hazardous if they are inadvertently exposed to another person or to the patient even by different routes. There's absorption via skin or mucous membranes, injection, which if you stick yourself accidentally with a sharp that may have the chemotherapy in there, inhalation, which means you're breathing in dust, droplets, or drug aerosols when the chemotherapy is being mixed or administered, and ingestion. You're mixing the chemotherapy, you're administering the chemotherapy, and then later on you don't wash your hands or what have you, and you touch your mouth or your nose. Washing hands with soap and water before and after every chemo administration is strictly followed by all staff giving antineoplastics, as well as several other things like wearing PPEs. PPE stands for personal protective equipment, and in the picture we have here, we notice a chemotherapy nurse wearing special chemo gloves, a gown, and a face shield to protect her eyes. Whenever we do give chemotherapy, we will dress just like this. We don't always wear the goggles. That is not a given. It's just a recommendation, but we always wear specially designed gloves for chemotherapy and low permeable gowns, which means if we get something splashed on us, it won't soak into and get into our clothes. There are some special requirements that we do follow if chemotherapy is spilled or leaked onto the floor or an inanimate object. Chemotherapy dosing is very precise for the patient. As previously mentioned, treatment plans and protocols are individualized for every patient. This includes adjusting chemotherapy dose amounts each time the patient is to receive chemotherapy. Safety is a priority when administering chemo, and each order is verified against the patient's current height and weight, pertinent lab values, the patient's performance status at this time, and the patient's report of how they tolerated their previous chemotherapy treatment, like did they have a lot of diarrhea, a lot of nausea and vomiting, things like that. Have they lost weight? Is their appetite so poor they can't maintain a healthy weight? These are all things that we will assess in addition to other things before we even order the chemotherapy. Once the chemotherapy is ordered by the physician, the pharmacist verifies the accuracy of the computer physician order entry, or the CPOE entered dose, related to the information that we have reviewed, the lab values and whatnot. And then it will be checked again by the administering RN and one other nurse prior to actual giving of the chemotherapy. Another safety process involves patient identification and patient's chemo labeling with barcodes so that we can scan each drug with the patient's electronic health record against the scanning barcode on the medications that were specifically ordered for that patient. This is done by each RN before they administer any antineoplastic. Some lab considerations that we look at include platelet count of greater than 100, absolute neutrophil count of 1,500 or above, and this is their mature white blood cell count. It's not the WBC, but it's a component of that. A creatinine less than 1.5, which means their kidney function is good. A BUN that's within normal limits for that patient. A magnesium, which is within normal limits for that patient, receiving cisplatin in their Erbitux or some other magnesium-stealing chemotherapies. And a urine protein less than 4+ if the patient's getting Avastin. Some of these have relative values depending on the kind of chemotherapy the patient's getting, and we may give the patient chemotherapy if they're lower than this, but that is specific for each chemotherapy and each patient. Another thing we look at, as I spoke about, was the patient's performance status. Performance status is really important because it relates to how well the patient's activities of daily living are, what their quality of life is. Because honestly, living a long time is okay if your quality of life is good as well. So we want to make sure that the patient has a good performance status. We have scales that ECOG is one of the ones that we follow. ECOG is just one of those NCCN research facilities that we utilize when we're trying to determine what kinds of chemotherapies are going to be best for protocols. But as you can see, the ECOG goes from 0, 1, 2, 3, and 4. Some scales that you see may have a 5, which means death, but most of the time we just use 0, 1, 2, 3, or 4. These are subjective answers by the patient, and it all relates to how the patient actually feels themselves. Another factor that can affect a patient's response to chemotherapy is called tumor burden. The smaller the tumor, the higher rate of response. The larger tumor, the higher the risk for developing tumor lysis syndrome, depending on what kind of a cancer the patient has. This is particularly true if the patient has a lymphoma or a leukemia, because there's a lot of bulky systemic cancer cells in there that once we give them chemotherapy, they start dying quickly, and all of those killed cancer cell byproducts spill out into the system. And if we're not careful, the patient can become very sick and develop tumor lysis syndrome. Another thing we're concerned about is the rate of tumor growth. Some chemotherapeutic agents act much more effectively against cells that are very rapidly growing, and most chemotherapies do affect rapidly growing cells such as hair follicles, skin, GI system, your mucosal lining, and those kinds of things. But this, when you talk about tumor burden, this is why it's so important when people are having symptoms that they go to the doctor so they can be tested to see if they do have a cancer, because the smaller the cancer is, the easier it is for us to treat almost every single time, and the less likely they'll have metastasis, because once it metastasizes, that makes it more difficult for us to take care of business. Other factors that can influence when a patient gets chemotherapy, or how much, or what that kind of the treatment they're getting, includes their comorbidities, which is, are they obese? Do they have high blood pressure? I mean, you can see the pictorial here, diabetes, gallbladder disease, kidney disease, anything that's going to make it more difficult for them to tolerate the chemotherapy. Another factor has to do with coping and emotional state. Some people just may prefer not to get chemotherapy. Maybe they're older and they don't want to go through that, or what have you. But these are things that we have to determine and assess before we start treating the patient. Chemotherapy dose intensity refers to the dose of chemo that is delivered per time frame delineated per protocol standard and is expressed as milligrams per meter square per week. Whew, that was a lot, right? All that's talking about is how much chemotherapy are we going to give the patient in a certain time frame. Most protocols tell us that, for example, a patient's going to get this chemotherapy every 3 weeks like clockwork, unless something happens to their side effects and their counts are too low or their performance status is too low. And so then we might have to reduce how much chemotherapy we give them, or we might have to delay treatment for a week. Delaying treatment is really not a good idea, because we know that if we stay on protocol, that patient has the best chance of surviving this cancer and possibly getting a cure. So one of the most important things providers try to do is be proactive in symptom management so that we can prevent delays in treatment. There are several complications for chemotherapy that we're going to discuss. The first one is anaphylaxis, and I'm sure you all know that means a severe allergic reaction. That does happen from time to time. It does not always mean that the patient won't get that drug again. There are some things that we can do, but if we treat them with pre-medications and we give it again and they react again as severely, they will not receive that medication again. Another complication is hypersensitivity. It's like it's kind of similar to an allergic reaction, but it's more controlled. And these are the people that can receive a medication. They're sensitive to it, so we know that. So we're going to give them medications before we give the chemo, so that they don't have those side effects and those reactions. A flare reaction is just local redness, irritation. It's nothing serious, and it's nothing we're going to hold the chemotherapy for. Irritation would be a local reaction to the chemotherapy, and it's typically very short acting, and again, it's not going to be anything that we're going to stop the chemotherapy or hold it for any length of time. And extravasation happens when that toxic chemo agent gets into the body tissues. And vesicants are the most serious because they can actually cause skin to slough off. The one thing I want to say about this is, just because your IV has a good blood return does not mean that everything you're giving via that IV is going the right place. So you always have to be very careful and assess your IV site very well before you give any chemotherapy. Some other side effects to be talked about are myelosuppression of the bone marrow, thrombocytopenia, anemia, and neutropenia. Thrombocytopenia means low platelet count. Anemia means the patient's H&H, or hemoglobin, and hematocrit are decreased. Neutropenia means their white blood cell count, specifically their ANC, or absolute neutrophil count, which we mentioned earlier, is too low to give. Now, of all of these, anemia would not be one that would make us hold the chemotherapy unless it was extremely severe, like 6 or below. Thrombocytopenia and neutropenia, on the other hand, may be a dose-limiting or an intensity-limiting side effect, and we would hold the chemotherapy possibly, depending on how low it is. Another chemotherapy side effect is radiation recall to previously irradiated skin. For example, if someone has received radiation to the breast, and then later on we give them a certain chemotherapy, that can cause their breast to have that sunburned effect again and to have some reaction. Nausea, vomiting, diarrhea, and constipation are some other problems. Mouth sores, loss of appetite, food taste changes, loss of hair, fatigue, vision changes, electrolyte imbalances, loss of sexual drive, sterility, peripheral neuropathy, watery eyes, and dry vaginal tissues are all side effects that can happen depending on what kind of chemotherapy the patient's receiving. We do extensive education for the patient and let them know about these, and there's also things that we can do about many of them. Some we cannot, and in those cases, for example, sterility, we will take precautions and offer the patient the option to make preparations in case they want to have children later. Some other chemotoxicities that we're concerned about are secondary malignancies, which means you can get chemotherapy for treatment today of non-Hodgkin's lymphoma and then 10 or 15 years later develop leukemia or something else. Typical secondary malignancies, depending on the type of chemo treatment or the type of cancer you had previously, are leukemia, brain cancer, bone cancer, and bladder cancer. Other toxicities we worry about are toxic chemotherapy effects to the heart muscle or the cardiac system, the lungs or pulmonary, bladder, liver, kidneys, birth defects, hearing loss, skin sloughing and rash, and peripheral neuropathy, which means their fingers and toes become numb and sometimes they can't feel things when they pick them up. And then we've already talked about a little bit tumor lysis syndrome, which is TLS. Remember, we talked about that when all the chemo cell or the cancer cells die and all their byproducts spill off into the system. Many cancer treatments pose post-administration concerns due to development of potential side effects. General patient education includes treatment-specific side effects as well as preventative care teaching. All of this is given prior to the patients receiving any chemotherapy treatments. Patients need this information so they can be fully informed before deciding to receive chemotherapy or refuse treatment. Maintaining good personal hygiene plays an important role in reducing harmful bacteria that can cause problems for patients who have immune systems that are compromised, such as those receiving cancer treatments. Preventative measures include having good hand washing, bathing daily with good perineal care, protecting their skin from cuts and burns, doing mouth care 3 to 4 times daily with salt and soda solution. We really don't want them to use alcohol-based products because they can irritate those fast-growing oral mucosal cells. They need to wear gloves for protection when working in the garden. You don't want anyone to get stuck with a thorn or something that may have a fungus. Exercising daily is quite important. In addition, if they have any children in their families or with friends or what have you that have received their yearly immunizations or their immunizations which most children receive when they're born, age 5, age 14, and so forth, the patient needs to stay away from those children for 30 days. Chemo is excreted in bodily tissues, and it's very important for the patient and their partner to wear protection during sexual intercourse. This helps reduce exposure risk to any chemotherapy byproducts that may be being excreted. So let's talk about oncologic emergencies. We've already mentioned tumor lysis syndrome or TLS several times, so I'm not going to go over that again, except to say that the way we treat this is prevention. Hydrating the patient and making sure their kidneys are flushing out all those cellular byproducts that have died during cell kill of the cancer cells is imperative to prevent TLS. Hypercalcemia often occurs when the patient's calcium in their blood is too high, and it can be caused by cancers that affect the bone like myelomas or leukemias, or cancers that have metastasized to the bone. This breaks down the bone and releases calcium into the patient's blood, which can cause too much calcium in their blood serum. We talked about the importance of exercise to reduce fatigue, and this is also important to help keep their muscles and bones in good, strong shape because exercise will help prevent that bone breakdown. Dehydration can also decrease how well the kidneys excrete calcium that normally needs to come out of the patient's body, and that can lead to hypercalcemia as well. DIC, or disseminated intravascular coagulation, is a disruption of normal coagulation states in the body where thrombosis and hemorrhage occur simultaneously. Some cancers can cause DIC, and this needs to be watched as far as any bleeding problems or what have you so that we can act on it properly and quickly. Superior vena cava syndrome is something that occurs most often in patients with lung cancers because the tumor may be compressing on the superior vena cava, causing a decreased blood flow in through the heart. What happens is the patient has increased pressure on the upper part of their body, and blood vessels can actually become engorged. The patient has trouble breathing, their face becomes very flushed, and this can be a very dangerous situation. Spinal cord compression occurs most often when the bone is affected by the cancer, and bony prominences may be growing and pressing into the spinal cord, causing a compression of the site. This is really an important thing to be watching out for because any neurological deficit that occurs over a 24-hour period could very well be permanent. So you really have to educate the patient on what to look for so that they can be aware. And as far as assessing the patient, asking the right questions can make all the difference in determining if this may be an issue. Sepsis and bacteremia is probably the most commonly occurring oncologic emergencies due to the fact that many patients getting chemotherapy are immunocompromised, therefore making them much more susceptible to being severely affected by any bacteria or virus. One of the things that we tell our cancer patients when we do chemotherapy education is to be very clear when they go to the emergency department with a fever or flu-like symptoms to let the ER staff know they are a cancer patient being treated with chemotherapy. Reason being, if they just go to the ER and have a fever and flu-like symptoms, what's going to happen? The doctor's going to treat them for flu and send them home. Well, in the case of a patient getting chemotherapy, this could be the first sign of them becoming sepsis or becoming septic and having bacteremia, which is a life-threatening situation. If they go home, they possibly could die. It has happened. Syndrome of inappropriate antidiuretic hormone production, or SIADH, occurs in about 67% of those diagnosed with cancer, and 70% of those are patients which have small cell lung cancer. Again, this is something that is prevented if we are watching out for it, and we'll look at the patient's sodium levels in their serum pretty often. One of the easiest ways to treat this is to make sure the patient doesn't drink too much plain water. I know all through our lives people say, oh, drinking a lot of water is good for you, but sometimes in the case of patients with cancer, that's not so true. That's the end of my presentation. If you have any questions, here's my contact information. Please feel free to email me at any time. You guys have a great day. Thank you.